welcome back. You're watching Health Mantra, and we are here with yet another highly qualified doctor from Manipal Hospitals to answer all our questions, our queries on various health concerns. But before we begin, let's first welcome Dr. Rohan Desai. Welcome to Health Mantra, Dr. Rohan. We are absolutely thrilled to have you here.
Thank you so much.
So, Dr. Rohan is an orthopedic surgeon and specializes in hip and knee joint replacement surgeries. So you might have guessed the topic for today. Yes, we are discussing our bones. So earlier today, Dr. Rohan mentioned that we observed World Arthritis Day last month. And according to a news report of 2021, around 1.3 crore people in India suffer from arthritis, which in terms of prevalence is higher than cancer or diabetes. Now, what exactly is rheumatoid arthritis? What causes it? What are the treatments available? Let's find out from Dr. Rohan Desai. So, doctor, when we say rheumatoid arthritis, what exactly is it?
See, rheumatoid arthritis is an inflammatory disease, or rather inflammatory arthritis, which normally typically affects a lot of females, rarely males. And it's a disease in which, your body's immune system starts attacking your own tissues. So your tissues could be joints in particular, but could be organs as well, like heart and lungs and livers and kidneys and skin. So it's basically inflammatory arthritis.
Okay, and doctor, what are the causes of it?
So as of now, we don't really know what are the exact causes for rheumatoid arthritis. We only know it's an inflammatory arthritis. But yeah, there is a genetic predisposition. So certain people who have a certain kind of a genome, which is called HLA2, they're prone for this kind of arthritis. Now, that is only possible when you do a genetic mapping of the individual. Now, in addition to that, it is commonly seen in females. So usually, the risk is 3 to 4 times much more in females as compared to males.
Okay.
Next, you also seen people who are prone for smoking. So people who have genetic predisposition plus smoking, you have seen the prevalence to be very high.
Okay.
Combination of factors, basically.
Okay, and doctor, what are the symptoms?
So basically, like any other arthritis, usually it starts with joint pains. So typically it involves the joints of your hands or your feet rather. So the small joints are usually very well involved. And typically it starts as a symmetrical arthritis. So now what we mean by symmetrical is basically it involves typically similar joints on both sides of your body. So usually you stand up with morning stiffness. So as you wake up in the morning, you'll have joint pains, which will normally ease out by afternoons. They are typical cases. Sometimes it may present only as one single joint involvement, like your knee may get just swollen, for some reason, and then you do your test and you get to know, or your ankle may get swollen. But usually, symptoms to begin with joint pains and swellings. Subsequently, if you don't treat them, they become worse and you end up in deformities.
Doctor, what are the diagnoses available?
Yeah, so once a patient presents to us in a clinic with this kind of symptoms, we would normally ask them for a few blood tests. So typically we ask them for something called a rheumatoid factor, which is a kind of an antibody which is normally seen in the bloods of them. So usually 70% of the people will usually have a positive rheumatoid factor. Some people will have another test which is called anti-CCP. That is usually sensitive in about 95% of the cases. So usually we do a combination of a few tests to prove that a patient has got rheumatoid arthritis.
Okay. And doctor, for management and drugs, what would you advise in arthritis?
So once we get to know the patient has got rheumatoid arthritis, normally the norm is basically we usually refer them to a rheumatologist. Okay. People who are trained to deal with this kind of patients, or else physicians who are trained with them. People to us normally present when they have deformities. So initial management basically from a rheumatology point of view is medications. So you start them on drugs. So in drugs basically you have a combination, a lot of drugs. So if we split it, basically drugs would be painkillers, which we call them non-steroidal drugs. Then some people use steroids, which people are usually scared and skeptical, but then normally the rheumatologists usually have start them on steroids. So the control initially is better. And you have something called disease-modifying drugs. Now disease-modifying drugs have been in the market for the last 20-25 years. So a lot of physicians and a lot of rheumatologists and orthopedic surgeons have used disease-modifying drugs, in which you have quite a few drugs. So those drugs are normally used to manage these patients. So whenever you start your treatment, normally it takes about 2-3 months for the effect to come. So usually what happens, patients, whenever they turn up in our clinics, they're very impatient in the beginning because they want to have something and then they want to get all right faster. But it doesn't happen so with the rheumatoid drugs. That's the reason in the first 2-3 months, you have to brace them up with some steroids or with some medications or some painkillers so that those drugs can take effect.
Okay.
So those are your drugs. Thereafter, the latest things which have come in the market are called biologics. These have come in the last 10-15 years. These are basically some kind of immunomodulators, because rheumatoid is an autoimmune disease. So use something called immunomodulators to deal with this disease, and these are used quite rampantly in the last 10 years, and they give very good results as well.
So what form do these come in?
They come in tablet formulations, they come in injectable formulations.
Okay.
The only issue, they're a bit expensive, but I guess all of these options are normally discussed with the rheumatologist, and you can take forward based on the patient need and based on what the rheumatologist feels about the treatment.
And doctor, what is the role of replacement surgery in this?
So before we speak about replacement, basically we have to understand, usually most of the patients in rheumatoid arthritis will have something called flares and remissions. Now flares are basically, they will have bouts of a few months, bouts of increased pain and limitation of activities, which normally last for a few weeks to a few months. So those are called flares. So usually when the patient turns up to us in flares, we have to assess their joints. So now if the patients turn up to us with, let's say, knee pain or hip pain for that matter, or an ankle pain, we normally do an X-ray. And we basically look for destruction of the joint cartilage. So if for some reason we feel the joint cartilage destroyed, that's when not destroyed rather, not destroyed, if for some reason we feel there's inflammation in the joint, but the cartilage is not destroyed, then we have a lot of options. We can try physiotherapy, we can try icing, we can try medications. If let's say they don't respond to them, then probably we try injections. Now injections could be in the form of steroids, could be in the form of some gels which are available in the market, but usually most of the patients will respond to this. And then they go back to a rheumatologist or their physicians and get treated, and they get things controlled. Issue happens when these people get neglected in the first 2 years or 3 years or 4 years or 5 years, or people try some other forms of treatment, and for some reason the control is not good. In that case, they come to us with deformities. Now deformities is a very big thing. They can have deformities from the fingers to their hands to their knees to their ankles to their hips, anywhere in the body, wherever the joints are. So if those joints get deformed, that's when the picture of a replacement surgeon will come. And that's when we offer them maybe a permanent option, which could be a replacement surgery.
And doctor, what about the revision surgeries?
Yeah, so revisions basically would come later on. So first we plan replacement surgeries. Now when we plan a replacement surgery, let's say for the knee or the hip joints, we normally plan for the bigger joints, the knee joints and the hip joints, which are very common. So when these people come with deformities, and when we talk to them and we discuss the problems, and when we finally decide that nothing is working for them, that's when the replacement comes into picture. So moment you do a replacement, usually they will have a very good life. So the joint can roughly last for about 15-20 years or maybe even longer. Now the only issue is, for some reason, if that patient stays longer, lives longer, let's say, if the patient comes to us early in their life, let's say in the 30s and 40s, and they require replacement surgery, thereafter if the joint lasts for about 15-20 years, maybe in the 60s or 70s, they would probably require a redo surgery, which is called a revision replacement surgery. But let's say for some reason the patient comes to us in their 60s, we can be rest assured whatever replacement we're going to do for them is going to last for a lifetime.
Okay. And doctor, who exactly is at risk now for our...
Yeah, so I rightly said, usually it affects the female sex, people who are genetically predisposed, having that certain kind of a genotype which is called HLA2, people who are who are prone to obesity, people who are already smoking a lot, so cigarette smoking. So these are all the risk factors, who are probably predicted, and people who are having a family history. So let's say somebody in your family, your mother, your uncle, or somebody else is having arthritis, and the risk of you having it is about 50%. So those people got to keep in mind that there's a possibility you may land up in arthritis, and have some regular checks.
Can you live a normal life with rheumatoid arthritis?
I think if the patient comes to us in deformity, and thereafter if we offer them replacement surgery, they will just have a normal life. Usually people come to us with deformities which cripple them. Some people are wheelchair bound, some people are bedridden. So those are the the ways in which patients turn up to us. So in those cases, when you do a replacement surgeries for them, whether it could be a knee replacement or a hip replacement, you put them back on your feet. So those people who are bedridden or who are wheelchair bound now start walking, and they can walk and they can do practically every activity. They can drive a car, they can dance, they can do practically everything. So you'll have a transformation in the quality of their life. That's what a replacement surgery will begin.
So doctor, what are the X-ray findings you see in a rheumatoid patient?
Yeah, so X-rays basically, when patients turn up to us, usually they can land up in deformities right from your fingers to your wrists shoulders, hips and knees and ankles. So typically, if you do exercise of the hands, you may see the fingers are probably like going outwards, or you may see like a different deformity like of the thumb, wherein like the thumb like usually goes inside. It's called a Z deformity or a Z-shaped deformity. Now similarly, if you do X-rays like of the wrist joints, okay, these are the joints like which you should do X-rays in the beginning, because you can really pick up a rheumatoid arthritis even though the blood tests are negative. So typically what you see on an X-ray is you see joint destruction, you see a reduction in the gap which is normally present like in any joint, and you see deformities. Now if you do an X-ray of the hips or the knees, again you will see joint space reduction. So normally every joint, when you do an X-ray, normally you see some kind of a gap. That gap is cartilage, which normally doesn't get picked up when you do an X-ray, and hence it is seen as a gap. So gap is normal. Now in these patients, like when you have a deformity or when you have destruction, like the gap will reduce in size and ultimately you will see no gap. So you'll reach a stage wherein the bones are rubbing against each other and there's no gap there. So this is what we look for. Now the difference in a rheumatoid arthritis patient X-ray vis-a-vis a patient who's got osteoarthritis, which is a different form of arthritis, is rheumatoid arthritis, typically in the knee, will destroy all parts of the joint. So you will not see any gap in any part of the joint. Whereas in osteoarthritis, it's the other way around. You will usually see a destruction of only one compartment. Unless you're in very severe stage, you will see destruction of all the compartments. So that's how you can diagnose very well sometimes even on an X-ray whether this patient has got a rheumatoid arthritis or whether he's got a osteoarthritis. Similarly, the same kind of picture you'll see like in hip replacement, in hip arthritis, which are rheumatoids. You will see global destruction. Global is like all around. The whole thing is destroyed, complete cartilage destruction, and absolutely no gap whatsoever. Now, very importantly, in these patients, you see something called osteoporosis, because these patients usually on medications like steroids and painkillers and allopathic and homeopathic and different kinds of medications, which make them prone for osteoporosis. The bones become soft. In addition to that, like they are also not very mobile because of the pain. So that also causes disuse osteoporosis. So on X-rays, you can also see the bones are quite fragile. So these are all the things that what we see on X-rays.
So doctor, when you say fragile on X-ray, what exactly does that mean?
I mean, they look very soft as compared to a normal bone. I mean, when you like, if you take an X-ray of the same patient like in the same age group, and you compare it like with a rheumatoid patient of the same age group, you see like these bones are softer. So the risk of fractures are a lot more in these patients if they have a fall, let's say, or for some reason patients.
Okay. So doctor, what complications do you expect while you're doing replacement surgery in a rheumatoid patient?
Yeah, so the biggest complication what you can see is fractures. Because for the simple reason, because these patients normally like have weak bones, because they're already on a lot of medications, as I said before, like steroids and all. So that basically like makes them prone for osteoporosis. So typically when we open the knee or when we open the hips and we do a replacement surgery, in the middle of surgery we can sense, we can see for ourselves that the bones are quite soft. And so usually we end up using cemented implants for them. Okay, usually in the hips we do a lot of uncemented implants wherein we don't use a cement. But normally in these patients we have to keep those cemented implants as a standby. So we may have to use a bone cement to fix those implants in their bones because the bones are softer. Second, you have to be very careful while operating because like you can cause inadvertent fractures. So that typically depends on your technical expertise of a surgeon to be careful, to brace up, to have all the possible implants on table, so that like you can deal with any complication thereof. So those are the most important challenging things which we face as a replacement surgeon when we do surgeries for these patients.
So doctor, after a replacement surgery, how long does a patient take to get back on his feet?
Yeah, so in Manipal, basically, for the last few years, we have been promoting something called fast-track replacement surgeries, which has become a norm all across the world. So typically, the patient gets admitted on the night of surgery or the morning of surgery, and the surgery takes about 40 minutes or 45 minutes. Thereafter, once the patient comes out of anesthesia, within a few hours, 3 or 4 hours, the patient is like put back on his feet. So he's made to stand, he's made to walk. There are no stitches, everything is under the skin. And you will just have a very small scar because all the surgeries normally nowadays are done minimally invasive. So after replacement, the protocol is very simple. You're made to stand, you're made to walk, you're made to do all the exercises within a few hours of surgery. Thereafter, you spend a day in the hospital just to make sure you receive the antibiotics and the painkillers. And the very next day, you get to go home. Now, this is a protocol for a patient who's undergoing a single knee replacement surgery. But for some reason, if the patient has got both knees involved or both hips involved, and they have to simultaneously undergo both knee replacement surgeries, then those patients usually will end up staying for about 2 or 3 nights. That's because we want to make sure there are no complications. We want to make sure they're adequately mobilized in terms of walking and exercising and all the stuff, and then they get to go home. So once they're home, we usually expect a home-based physiotherapy program which goes on for 3 weeks to a month or 2 months or 3 months, depending on the patient's recovery. And we usually assess them on a monthly basis for about 2 or 3 months. So usually, if everything goes smooth, we can expect the patient to walk without support in the next 2 or 3 weeks. Usually a month, we ask them to walk within the house just to be comfortable. After a month, if they're very comfortable, they can move out of the house and go for a short walk. By 2 or 3 months, we can expect them to walk a distance. That could be a kilometer or 2 or 3, depending on how much of effort the patient is putting in physiotherapy. When it comes to driving a car, if the patient is mobile enough, I think 6 weeks is a good time following a replacement surgery to go back to driving a car. If it's a hip replacement, then there are a few do's and don'ts which you have to follow, which I'm sure any physiotherapist will talk to them. You got to keep a pillow between your thighs when you go to bed. If you want to sleep on your side, you got to stuff a pillow between your thighs as well, just to make sure the hip stays in place. For the first 6 weeks, you should try not to sit on low stool. You should sit on the higher surface. Your hip should not bend more to 90 degrees. So there are a few restrictions from the hip point of view, but from the knee point of view, you can get back to your life fast.
Okay, so doctor, what are the latest advances that we can see in Manipal Hospital in terms of a replacement surgery?
Yeah, so Manipal Hospital is quite equipped with all the latest technology in terms of having a space suits to laminar airflows, which are required basically to bring down the risk of infection, which internationally is less than 0.5%. I mean, Manipal, touchwood, for the last 10 years, we were having a very good ratio of, we've not had so far any gross infections the last 10 years. Our surgeries are very quick. The surgical time is very small. We do something called minimally invasive replacement surgeries, wherein the cuts are very small. We don't normally have very big cuts which go across your knee. So the cuts are just small enough for the implants to fit inside. You're mobilized very fast. As I said before, within 3 or 4 hours, you're put back on your feet. You get to stand, you get to walk. You get to go home the very next day if you're doing a single knee replacement surgery or a single hip replacement surgery. So you get home fast, you start with your physio faster, and then your part to recovery is hastened.
Talking about the treatment, especially drugs, when does a patient need knee injections?
So when a patient turns up to us in a clinic and he's got, let's say, knee swelling, and of course we do x-rays and we know for sure this is rheumatoid arthritis. We have done the blood test and we already know. And for some reason the joint is not destroyed or the cartilage is intact. So that's when we probably may offer a steroid injection. So normally, as per the American Rheumatology Association, we are allowed to offer about 2 or 3 injections in a year in those rheumatoid patients. So the advantage of a steroid injection is it will give you a quick relief, because in rheumatoid arthritis you get something called synovitis. Every joint in your body has got a tissue which is called a synovium, which normally secretes some fluid. So that tissue is called synovial tissue, or synovium rather. These patients who have got rheumatoid arthritis normally have inflammation of the synovium, and so the synovium becomes thicker, and that is called a pannus. So that normally eats up the joint. So when these patients turn up to us with knee swelling or let's say hip swelling, usually the knee swelling, we usually offer them a steroid injection if we feel they are the right candidate for a steroid injection. Because people are usually scared and skeptical about a steroid injection. So that's the reason I'm saying if the patient has to be a right candidate for a steroid injection. Now what does the steroid do? It's a very potent and very strong anti-inflammatory agent. So the moment we give the injection inside the knee, it will decrease the synovial tissue. It will shrink it. So the swelling which is there, which is so big and boggy, will just come down. So that shrink basically gives a good relief. Now the effect of course may last for a few months. We don't expect the effect to be lasting for years and years together, but it's temporary just to bring down the pain and the swelling and the inflammation of the joint so the patient can do his activities. In that time, he's also on other drugs, which is disease modifying drugs, which will take effect. So this swelling normally happens only when they're not under control. So they have to revisit their rheumatologist or their physicians or their orthopedic surgeons to make sure the treatment is taken properly, or else you have to adjust the dose of treatments, or else you adopt new drugs.
Okay. Doctor, is there any particular diet that can help a rheumatoid arthritis patient?
Yeah, so I think a diet which is rich in antioxidants is something which we recommend, and also the rheumatologists we also recommend. So lots of green leafy vegetables, lots of colorful fruits, which will offer different kinds of antioxidants like berries and blueberries and strawberries and different kinds of fruits. Okay, capsicums, So basically something which is colorful in terms of fruits and vegetables that would offer you a lot of antioxidants. So those normally offer benefit from joint pains.
Okay.
We also recommend having a bit of turmeric, because turmeric is supposed to contain an ingredient which is called curcumin. Nowadays we even get medications which have curcumin inside. You get tablets available which have got curcumin. So that basically usually helps in inflammation, bring down inflammation, and avoid as far as possible spicy food. So you don't want something which is hot and sour and which is heat, basically heat producing. Basically, we want something which is going to tame down the heat in your body. So these things are very beneficial.
Doctor, thank you so much. This was really helpful for those who are not aware. I'm sure this really did help them understand the disease better. It was really nice having you here.
You're most welcome.
So, for those of you who wish to consult Dr. Rohan Desai, he's available at Manipal hospitals from Mondays to Saturday. And those of you who are suffering or have any symptoms, do not worry, because nowadays we have so much betterment with treatment that, of course, it's a lot easier to get back on your feet.